Assalamu alaikum. Welcome to today's Journal Club. Uh, this time we have a meta-analysis on a few famous trials. The topic is efficacy and safety of sacubitril-valsartan in heart failure. And this is a meta-analysis of few randomized control trials. Dr. Omar Idris Mufti, who is an interventional cardiologist and head of cardiology department in Maruf International Hospital, is going to present a meta-analysis, and afterwards we'll have a discussion and then critical appraisal of this journal club. So please start.
Can you hear me all? So first off, I want to say thank you for allowing me to give the first presentation of the new year. So from the cardiology perspective, I wanted to choose something that is actually under-recognized and underutilized from our standpoint here in Pakistan, and those are the ARNIs, or the angiotensin receptor neprilysin inhibitors, which is sacubitrl-valsartan. So I chose this efficacy and safety of the ARNIs in heart failure, and it's a meta-analysis of randomized controlled trials. So this is going to be a rather lengthy presentation from a couple of perspectives, because I wanted not only just to go over the meta-analysis itself, but I wanted to sort of refresh our memory as to the background, definition, classification of heart failure, talk about the major landmark trial which all these newer, this new medicine is based upon, which is the Paradigm Heart Failure Trial, and then discuss briefly, very, very briefly, about other ARNI trials that are out there, and then finally come to the meta-analysis. So jumping right in, the definition of heart failure, there are two definitions. There's the ESC definition and then the ACC-AHA definition. So heart failure is just a syndrome. It is a clinical syndrome with typical symptoms. So you're going to have shortness of breath, you're going to have lower extremity edema, you'll have fatigue, you'll have on exam, you have elevated JVP, you'll have crackles, you'll have the peripheral edema, and it's all caused by either a structural and or functional cardiac abnormality that reduces the cardiac output and leads to an elevated LVEDP, or left ventricular end diastolic pressure, that occurs during rest or at stress. The other definition is heart failure is a complex clinical syndrome that results in any structural or functional impairment of the ventricular filling or ejection. So that includes both diastolic and systolic heart failure. So chronic heart failure can be either with a preserved, reduced, or a mid-range ejection fraction. So when you're looking at it, we typically, when we think about heart failure and the general population thinks about heart failure, they think about heart failure with a reduced ejection fraction, so an EF less than 40%. That is heart failure with reduced ejection fraction. You have the mid-range, which is 40 to 59%, and then you have the preserved ejection fraction, what was classically called diastolic heart failure, which is an EF greater than 50%. Now, all of the medicines and all of the therapies out there, there is no current prognostic improvement with the current heart failure therapy in diastolic heart failure. You have vast medicines out there that have been shown to improve morbidity, but mortality still remains high in terms of systolic heart failure. And in the mid-range, it's in a gray area as always. So heart failure, as you know, is a common condition. The prevalence is about 1 to 2% of the adult population in developed countries has heart failure, and the prevalence increases as you age. So it rises to about greater than 10% in people over the age of 70. There are about 870 new thousand cases of heart failure diagnosed in the United States each year. And at age 45, your lifetime risk of heart failure from 75 to 95 ranges from about 30 to 45%. Now, the mortality rate for heart failure with chronic heart failure is as high as 50% at the 5 years post-diagnosis. So why do we care? We care about heart failure because if you look at it from the hospitalization standpoint, your first hospitalization, you tend to recover, but with each subsequent hospitalization, your length of stay in the hospital tends to be longer and your recovery tends to be more prolonged. So they were looking, when they came out with these new medicines, they were looking for some sort of treatment that can prevent hospitalization for heart failure and therefore help reduce your morbidity and eventually help reduce your mortality as well. So when you look at the classification of heart failure, there are two major classifications. You have the ACC classification and you have the New York Heart Association classification. I tend to like the ACC classification because once you're in that area, in that stage, you can never go back. So like stage A, if you look at stage A, at high risk for heart failure, but without structural heart disease, those are patients who have, let's say, hypertension. So they're at high risk. They're hypertension and they're diabetic. They have high risk, but they have no signs of heart failure. But when they develop any symptoms and they have structural heart disease, they're either in stage B or C. You can never go back to stage A. While in the New York Heart Association classification, you can come in at a class 4, meaning you're unable to do any physical activity, your symptoms occur at rest, and by the time you get discharged from the hospital, you can be at class 2 or even class 1 possibly, but unlikely. Now, why do we care? The objectives in heart failure are going to be to improve your clinical status of your patient, to improve the functional capacity, and more importantly, the quality of life. And then from our standpoint, prevent hospital admission and reduce the mortality. Now, all the heart failure drugs that were out there were based, you had your ACE inhibitors, you had your angiotensin receptor blockers, you had your beta blockers, and your aldosterone blockers. Now, when you look at the old trials, enalapril was based on the SOLVE trial and the consensus trial. Candesartan was the CHARM trial. Beta blockers, you had the MERIT trial, the Copernicus trial. And then for the aldosterone blockers, you have the RAILS and the Emphasis and even the Ephesus trial. Now, ever since that time, the RAILS and the Emphasis and the Ephesus were the more recent ones, which were like around 2004, 2005. There was no new therapies out there in heart failure. Then came along the landmark trial, which is the Paradigm Heart Failure trial, which was was published in 2014 in the New England Journal of Medicine. And this is the basis for all the ARNIs that are out there, angiotensin receptor neprilysin inhibitors. So this trial itself was pivotal in the way we're treating heart failure today. So looking at the Paradigm Heart Failure trial, you had key inclusion and key exclusion criteria. So the inclusion criteria were anyone with New York Heart Association class 2 to class 4, LVEF less than 40. They had to have a BNP with greater than 150 or greater than 100 and a hospitalization within the last year for heart failure with reduced ejection fraction. They had to be on stable treatment with an ACE inhibitor, angiotensin receptor blocker, and a beta blocker. All the prior trials did not have that guideline directed medical therapy with addition of a beta blocker. And then they could be on an aldosterone antagonist as well. Now your exclusion criteria was your angioedema, your EGFR, if you're CKD stage 4 or less, if your serum potassium was greater than 5.2, if you had symptomatic hypotension, so systolic blood pressure of less than 100, or if you actually currently had acute decompensated heart failure. Now, the Paradigm Heart Failure trial split people up into giving them ACE inhibitors for 2 weeks. Then they switched them over for about 1 to 2 weeks to the ARNIs, which is sacubitril-valsartan, which here in Pakistan goes by the name of, there are multiple trade names for it. You have Euperio, you have Sacvin, and so forth. And so they gave that at 100 milligrams twice a day for 1 to 2 weeks, and then bumped up to 200 milligrams twice a day. Then you had the double-blind treatment period where they were randomized 1-to-1, and either you received the ARNI or you received enalapril. And the median follow-up in this trial was 27 months. It was the largest heart failure trial to date. It enrolled around 8,500 patients and 985 sites in around 50 countries. Now, the primary endpoints were death from cardiovascular causes or first hospitalization for heart failure. And as you can see, looking at this graph, there was a 20% relative risk reduction of the primary endpoint, which was death from cardiovascular disease or first hospitalization. And you can see the curve split as the days go by. Then you look at the death from cardiovascular causes alone. There's also a 20% relative risk reduction in the primary endpoint with the use of the ARNI. And then the p-value is 0.001. Now, you also had a 21% relative risk reduction in your first hospitalization for heart failure as well, with also a very significant p-value. Now, the death from any cause, the relative risk reduction was 16%, which is still with a p-value of less than 0.001, which is significant as well. Now, looking at the paradigm heart failure trial, the summary is that you had a 20% risk reduction across the board, and you had fewer heart failure symptoms and a better quality of life. And actually, that's why when they released the newer guidelines for heart failure, they had moved the ARNIs up to class 1 or class 1A level. Now, when you look at other ARNI trials, and the reason I want to go over these is because these trials were all incorporated into the meta-analysis we're going to discuss. So you had the Pioneer heart failure trial, which looked at initiation of an ARNI is safe and effective among patients hospitalized for acute decompensated heart failure. As you recall, when we just went over the paradigm heart failure trial, those patients actually needed to get enalapril first, and then were given the ARNI, and then after that were randomized. So the Pioneer trial looked at possibly just starting you initially on an ARNI and skipping the whole ACE inhibitor, angiotensin receptor blocker up front. And the Pioneer heart failure trial looked at a greater reduction in your pro-BNP levels. You had the Paragon heart failure trial, which looked at compared ARNIs to valsartan in heart failure with preserved ejection fraction, because all those other trials were with reduced ejection fraction. Then you had in the Paragon heart failure trial, it showed that the ARNI did not lower your rate of total hospitalization for heart failure or death in patients with a preserved ejection fraction. So there's no difference. And that's when they took an EF of greater than 45% for preserved ejection fraction. But a subset of the Paragon heart failure trial did show a reduction in the pro-BNP with the use of an ARNI. Now, coming to the PRIME trial, this was tested to see if an ARNI can help reduce your functional mitral regurgitation. By functional mitral regurgitation, we mean mitral regurgitation that is caused by dilatation of the left ventricle, which then is due to structural abnormalities that occur with heart failure. And that was a double-blind trial that randomly assigned 118 patients to either ARNIs or valsartan alone. And it showed that the ARNI or the sacubitril-valsartan reduced your mitral regurgitation to a greater extent than valsartan alone. After that, you had the Paramount heart failure trial, which was a phase 2 randomized double-blind multi-center trial, which again took NYHA class 2 to 3 heart failure, EF 45% or higher, and a pro-BNP of greater than 400. The participants again were randomized 1-to-1 to either receive an ARNI or receive valsartan, and they were treated. The primary endpoint was looking at the change in your pro-BNP from the baseline to at 12 weeks. And then the findings were that patients with heart failure with preserved ejection fraction, the ARNI actually reduced your pro-BNP to a greater extent than simple valsartan did at 12 weeks, and was fairly well tolerated from the side effect profile. Coming next to the transition trial, this trial wanted to assess the tolerability and optimal time point of initiation of the ARNI in patients who were stabilized after an acute heart failure episode. So it was a randomized multi-center open label study, and it compared both treatments, and the initiation of sacubitril-valsartan in a wide range of heart failure did reduce heart failure patients with reduced ejection fraction stabilized after an acute event, either during hospitalization or after discharge, is feasible. So they thought that it is well tolerated, it's feasible, and a target dose of 200 twice a day, which is your end goal, can be achieved within 10 weeks. Now, there's a post hoc subgroup analysis of the transition trial, which showed that first-line initiation in patients who come in with reduced heart failure with reduced ejection fraction for the first time and they're being diagnosed, you can actually start an ARNI on them initially, along with other guideline-directed medical therapy, meaning your beta blockers, your diuretics, and so forth. And it's feasible with a better risk profile than in other patients. And then early intervention may be considered to delay disease progression in those patients with a new onset heart failure with reduced ejection fraction. Now, that was a quick and dirty look at all those ARNI trials, particularly the Paradigm Heart Failure trial. Now getting into the meat of our talk today, which is looking at the efficacy and safety of an ARNI in heart failure and this meta-analysis. So this was an original article that was published in the European Society of Cardiology, the Heart Failure Journal, and was published in September of this past year. So it was a meta-analysis to analyze the comprehensive outcomes of randomized controlled trials of heart failure, in which sacubitril-valsartan was compared with a RAS inhibitor alone. So the way they went about it is they did a systematic search using PubMed, Embase, the Cochrane Library, clinicaltrials.gov, from the inception of those entities up until November 21st of 2019. They searched for studies with medical subject headings and text that included things such as heart failure, cardiac failure, heart decompensation, left-sided heart failure, and so on. And then they used LCZ 696, which was the drug number that was given to sacubitril-valsartan when it was being tested originally. And then also used sacubitril-valsartan and Entresto, which is the trade name for sacubitril-valsartan over in the West. They searched randomized controlled trials using filters from McMaster University. They also searched corresponding references of each retrieved study. And the meta-analysis was conducted and performed by following the preferred reporting items in systematic reviews and meta-analysis. So the PRISMA guidelines, essentially. The selection criteria that they used were RCTs with sacubitril-valsartan group and a control group, randomized controlled trials including chronic or hemodynamically stable patients with acute heart failure, and then thirdly, randomized controlled trials analyzing primary efficacy outcomes, including death from cardiovascular disease, death from any cause, your hospitalization for heart failure, key adverse events, which we will talk about in detail, which include symptomatic hypotension, worsening renal function, hyperkalemia, and angioedema. Now, the exclusion criteria in the study were any duplicated papers related to the same trial, studies such as systematic reviews, comments, case reports, conference abstracts or editorials, and observational cohort studies, and incomplete randomized controlled trials or randomized controlled trials failing to report the outcomes of interest. Now, for data extraction and quality assessment, were performed by 2 reviewers. The data, including the baseline characteristics of the trials, interventions, comparison, sample size, medication, and follow-up duration was also analyzed. They looked at the outcomes, including death from any cause, death from cardiovascular causes, hospitalization due to heart failure, and then the adverse events, which were symptomatic hypotension, renal dysfunction, hyperkalemia, which was defined as a potassium of greater than 5.5, or serious hyperkalemia, which was defined as a potassium of greater than 6, and then also angioedema. The 2 reviewers who were part of this cross-checked all the data, and if there were any inconsistencies, it was resolved by a discussion or by referral to a third author. Now, for the risk of bias assessment, they actually, the methodological quality of the 6 randomized controlled trials that were finally looked at the end was assessed using the Cochrane collaboration risk of bias tool, which included selection, performance, detection, attrition, reporting, and other biases. Looking at your statistical analysis were performed by your review manager, which is the Copenhagen model and the Cochrane collaboration model. The efficacy and safety of the outcomes were measured as dichotomous variables and compared between the ARNI group and the control group. The pooled odds ratio and the relative risk ratio and corresponding 95% confidence interval were collected in the comparative analyses. And then heterogeneity in the meta-analysis was assessed using the T-squared test, the Cochrane's chi-squared test, and then and so forth. Now, coming to your results, the initial search that they did in PubMed, the Cochrane Library, and so forth, identified 315 records, and after removing all the duplicates. The full text of 46 articles from those 315 was reviewed in detail, and 40 articles were further excluded because those papers either related to the same trial, did not meet your inclusion criteria that we were looking at, or did not include real randomized controlled trials, or had no outcomes of interest. So in the end, there were 6 double-blind randomized controlled trials with around 15,000 participants that were included in the meta-analysis. All studies reported primary efficacy outcomes or key adverse events. So, and those included your cardiovascular mortality, your all-cause mortality, hospitalization for heart failure, symptomatic hypotension, your worsening renal function, your hyperkalemia, serious hyperkalemia, and angioedema. The sample sizes of the 6 randomized controlled trials ranged from 118 to 8,400 patients, and the follow-up duration was anywhere from 8 weeks to 35 months. And the risk of bias was assessed in the 6 studies and generally found to be low. Now, this is a diagram that shows how they went about selection. So as you can see, there were 126 records in PubMed, 156 in Cochrane, 81 in Embase, and then about 60 in the clinicaltrials.gov. So they excluded the duplicates after that, and they came down to 46 full text articles, 40 of which were excluded for the various reasons I discussed before. And then 6 were finally used in our meta-analysis. So the outcomes, primary efficacy outcomes that they were looking for in our meta-analysis was death from all causes, death from cardiovascular causes, and then hospitalization for heart failure. Now looking at all-cause mortality, you have, when they looked at all these studies, and the studies over here, as you can see, there's the Kang study from 2019. That study actually was the PRIME trial. You have the McMurray trial in 2014, which was actually your paradigm heart failure trial. Velasquez's 2019 study was actually your pioneer heart failure trial. And then the Solomon studies for the preserved ejection fraction heart failure were your Paragon and your Paramount heart failure trials. So as you can see by this graph, anything to the left, it shows benefit of sacubitril-valsartan. Anything to the right of that line shows benefit to the control group, which would be the ACE or the ARB. So as you can see, all-cause mortality in heart failure with reduced ejection fraction, there was actually benefit, and it showed a vast benefit in the sacubitril-valsartan group, because it doesn't even cross the line here in the McMurray and the Velasquez study, and the subtotal is to the left of that line. However, with heart failure with preserved ejection fraction, there was no difference between your sacubitril-valsartan or your control group. Coming to cardiovascular mortality itself, it shows similar findings. In patients with heart failure with reduced ejection fraction, ARNIs were superior, while in heart failure with preserved ejection fraction, there was no difference between your ARNI and your ACE inhibitor angiotensin receptor blocker. Coming to hospitalization for heart failure itself, once again, there's a difference here, but actually the difference is also with heart failure with preserved ejection fraction. As you can see, the benefit again is with the ARNI. Sacubitril-valsartan is to the left of all the findings are to the left of the line, which endorses use of sacubitril-valsartan for reducing hospitalization for heart failure, both in heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. As you can see at the bottom, the total is with the 95% confidence interval, it still shows improvement. So what about the main thing with this meta-analysis, which was looking at the efficacy and safety? So we're always concerned about the safety profile of medications in our patients. So this meta-analysis looked at the adverse events of interest, which were your symptomatic hypotension, worsening renal function, hyperkalemia, and angioedema. Now, for those of us who use these ARNIs, the most common thing that we see in our patient population is symptomatic hypotension. So that's going to be key here. So looking at this, when you look at it from the symptomatic hypotension standpoint, there's actually benefit to using enalapril or valsartan alone as compared to the ARNI, because the ARNIs caused more symptomatic hypotension. And that was noted in our first initial trial, which was the paradigm heart failure trial as well, which showed that symptomatic hypotension was much more in the ARNI population. What about worsening renal function? You would think that using valsartan, comparing it to enalapril or comparing sacubitril-valsartan to valsartan alone, that worsening renal function may be more so in the sacubitril-valsartan group. However, in actuality, looking at the meta-analysis, there's actually benefit to using sacubitril-valsartan. It doesn't worsen your renal function as much, which is kind of difficult to understand, because you're having, on one hand, you're having worsening symptomatic hypotension, which you would think would cause reduced renal perfusion, which would then lead to worsening renal function. However, based upon the meta-analysis, it all shows that there's actually benefit in slowing reduction in your renal function with the use of sacubitril-valsartan. Now, looking at serious hyperkalemia. Again, serious hyperkalemia was defined as a potassium level of greater than 6. Again, there's benefit with using sacubitril-valsartan as opposed to using the control. What about hyperkalemia itself? Now, hyperkalemia was potassium of greater than 5.5. Again, there's really some slight benefit to using sacubitril-valsartan, but as you can see at the end, the grouping at the very end, it shows that it crosses the line. So there's really no significant benefit, and it's kind of a wash. Coming to your angioedema, there's really no difference between the two groups. Now, all the studies that were included in this meta-analysis were actually all multi-center, randomized, double-blind, active controlled trials with low risk of bias. The participants in the trial had either reduced ejection fraction heart failure, preserved ejection heart failure, and ranged from NYHA class 2 to class 3. The data suggests that sacubitril-valsartan is superior to an ACE or an ARB in reducing your all-cause mortality, cardiovascular death, and hospitalization in patients with heart failure with reduced ejection fraction. However, there is no significant difference in all-cause mortality or cardiovascular mortality in patients with heart failure with preserved ejection fraction. And despite the association with increased risk of hypotension, sacubitril-valsartan showed a reduced incidence of worsening renal function and less frequent elevations in serum potassium, particularly in your serious hyperkalemia. And the incidence of angioedema was reduced and similar between both groups. Now, looking at the sacubitril-valsartan group itself, it showed superiority over enalapril or valsartan in terms of the primary efficacy outcomes. The composite risks of death from all causes and cardiovascular diseases were lower in patients with heart failure with reduced ejection fraction receiving sacubitril-valsartan. And regarding the outcome of all-cause mortality, the pooled odds ratio based on 3 studies was 0.83 with a p-value of 0.0006. Now, the odds ratio of cardiovascular mortality based on other 3 studies was 0.78, and the p-value was less than 0.0001. Now, there was no significant difference in all-cause mortality or cardiovascular mortality between the sacubitril-valsartan and the control groups in patients with preserved ejection fraction. So there's no difference there. And compared with enalapril and valsartan, sacubitril-valsartan did reduce the composite risk of hospitalization for heart failure by 21% based on 5 studies. And the p-value there is less than 0.00001. So very, very, very significant. And the subgroup analysis showed that use of sacubitril-valsartan had a similar benefit in reducing composite risk of hospitalization for heart failure in patients with reduced ejection fraction and patients with preserved ejection fraction as well. Now, the Paradigm heart failure trial, which was the initial trial we discussed, had a large number of participants, and sacubitril-valsartan reduced the risk of death from all causes, or even cardiovascular causes and hospitalization for heart failure. However, sacubitril-valsartan did not reduce the risk of death compared with enalapril or valsartan in several other trials. And that may be because of the smaller sample size, because as you recall, there were around 8,900, actually 15,000 patients in the Paradigm heart failure trial. 15,000 patients overall and 9,000 in the Paradigm heart failure trial. Now, compared with enalapril or valsartan, sacubitril-valsartan reduced the pro-BNP to a greater extent in the Paramount trial and reduced mitral regurgitation to a greater extent in the PRIME study. Coming to the Paragon heart failure trial, sacubitril-valsartan did not result in significantly lower rate of death or cardiovascular causes among patients with preserved EF, but it did reduce the overall risk of hospitalization, which is also key here. You don't want people to come into the hospital often. Want to keep them at home to improve their quality of life as much as you can. Now, looking at a recent post hoc analysis of the Paragon heart failure trial, it revealed that sacubitril-valsartan showed a gradient in relative risk reduction in primary events, from including total hospitalization and cardiovascular death, from patients hospitalized within 30 days to patients never hospitalized. And then a more favorable effect on the primary outcome was observed in those patients with an LVF of 45 to 57% compared with those greater than 57%. So meaning that if you're going to use an ARNI, like if you're going to plan on using a sacubitril-valsartan in a patient with preserved ejection fraction, there may be the benefit of that may be used when you're using it in higher risk patients. So patients who have an EF of around less than 55, it may be better than using it in patients who have an EF of 60% and have known diastolic heart failure. Now, the Pioneer trial, it showed that sacubitril-valsartan reduced the rates of clinical events. And these events were committee adjudicated cardiovascular death or rehospitalization in patients with post-acute decompensated heart failure. We had the Transition trial, which showed that early initiation of an ARNI was selected for patients with acute decompensated heart failure with reduced ejection fraction. And this was like a real world study that involved 932 patients with reduced ejection fraction heart failure, verified the effectiveness of sacubitril-valsartan. Now, based on your meta-analysis, sacubitril-valsartan increased the incidence of symptomatic hypotension with an odds ratio of 1.55 compared with enalapril or valsartan. Patients with a lower systolic blood pressure, both during the run-in phase and after randomization, but generally tolerated the ARNI, had the same relative benefits over an ACE or an ARB as patients with a higher baseline systolic blood pressure. And there was no difference in the number of participants or patients who needed permanent discontinuation due to hypotension. So it shows that if you slowly titrate up the ARNI and titrate it up so the patient slowly gets used to it, there's actually more proven benefit of it and in the endpoint. Now, in the titration study, you had patients with a lower systolic blood pressure achieved treatment success with gradual up titration, as I just mentioned, and suggested that a lower systolic blood pressure should not prevent clinicians from considering initiation of the ARNI. And then regarding the pooled evidence, the ARNIs led to a lower incidence of renal deterioration than enalapril valsartan. However, the incidence rate differed depending on the level of your baseline creatinine and EGFR. So looking at pooled evidence, sacubitril-valsartan led to a lower incidence of the deterioration, renal deterioration. However, that incidence rate differed depending on your EGFR. And in clinical practice, patients with all stages of kidney disease who receive treatment with an ARNI have fewer cardiovascular deaths or hospitalizations for heart failure than those treated with your standard therapy. So according to the pooled analysis of the serum potassium concentrations greater than 5.5, there was no difference between the two groups. Although the concentrations were found all of these concentrations were found to be 13.2% in the sacubitril-valsartan group and 15.3% in the valsartan group. Now, the rate of serious hyperkalemia, which is potassium greater than 6, in the sacubitril-valsartan group had a lower rate of the serious hyperkalemia with a p-value of 0.0007. And that was based on the Paragon heart failure trial, the Paramount heart failure trial, and the Paradigm heart failure trial. Now, angioedema was low in each trial, and there's no significant difference between the two groups. However, the sensitivity of analysis showed a higher incidence of angioedema in the ARNI group after excluding the Pioneer heart failure trial. So in the end, sacubitril-valsartan is the first drug indicated to be superior to enalapril in reducing mortality or hospitalization rate for heart failure in patients with heart failure, and shows potential to improve the outcomes of patients with heart failure. Sacubitril-valsartan blocks the RAS system and enhances the activity of the vasoactive substances, which actually leads to an associated higher risk of symptomatic hypotension, but there was no increase in the discontinuation rate due to adverse events associated with that hypotension. And the greater hypotension caused by the ARNIs might impair renal perfusion. However, as I mentioned before, several trials involving the heart failure population, including the Paradigm heart failure trial, suggested that the ARNI showed a slow decline in the renal function compared with the ACEs or the ARBs alone. And discontinuations of the study drug due to renal impairment were less frequent in the ARNI group. So based on the pooled analysis, sacubitril-valsartan slowed the elevation of serum potassium as well when compared to ACEs and ARBs. Now, the limitations of this meta-analysis that we just went over, the number of trials was low. There's only 6 trials that we included. Funnel plot was not suitable for sensitivity analysis. There were some confounding factors such as heart function, baseline blood pressure, age, sex, other potential factors which were difficult to control. There's certain unpublished data or articles published in other languages that were not included. There was varying sample sizes and different control drugs that may have led to confounding bias and affected the composite outcomes. And the meta-analysis may be underpowered for long-term adverse events comparison between the ARNIs and the ARBs or ACEs due to different durations of the randomized controlled trials that were included in the study. So in conclusion, pooled estimates showed that comparing ACEs and ARBs with sacubitril-valsartan, there was a significantly decreased risk of death from all-cause or cardiovascular causes and hospitalizations for heart failure in patients with reduced ejection fraction heart failure, but failed to improve all-cause mortality and cardiovascular mortality in heart failure with preserved ejection fraction. Sacubitril-valsartan increased the risk of symptomatic hypotension. However, it slowed the decline of kidney function and elevation in serum potassium concentration compared with ACEs or ARBs alone. And angioedema occurred less frequently in the sacubitril-valsartan group, but there was no statistical difference between the ARNIs or the ACEs or ARBs with that. And with that, I thank you guys, and I'm open for any questions.
Thank you, Dr. Omar. It was a nice presentation. If there are no questions, we can start the critical appraisal. Sir, can you hear me?
Yes.
So, starting with the critical appraisals, the first questions are the results of the review valid. So, definitely, this forest plot that you had shown, we saw that sacubitril-valsartan reduced hospitalizations and decreased cardiovascular mortality. So, I think this should be a yes.
Yes.
Is it unlikely that important relevant studies were missed? Okay, so
So looking at that, I mean,
told that they had incorporated. Yes, sir. You were saying something.
yeah, they incorporated MedLab, they incorporated your Cochrane, they incorporated PubMed, they incorporated everything that they had up until that date. And the ones that were missed were the ones that were in different languages. So were unpublished data, and then things such as abstracts and so forth that were presented at conferences.
So I think that's a yes.
That's a yes as well.
That's a yes. Were the criteria used to select articles for inclusion appropriate?
That would be yes.
Yes, exactly. Were the included studies sufficiently valid for the type of question asked? I think there was a definite yes.
Yes.
Were the results similar from study to study?
So the only difference there was that some of the results were a little bit different because some of the trials were comparing reduced ejection fraction and then preserved ejection fraction, which the more benefits with reduced ejection fraction, but there's similar efficacy across the board, meaning safety profile across the board.
So in the forest plot where the combined outcome was shown, the first study, it was a little bit different. The outcomes were different. Otherwise, in the other two studies.
Correct. So that was different. So that's the only thing. So you can put down, I mean, based upon the chi-squared though and everything else, I think that looks about, I think it'll be a yes based upon that. But
are there any comments from other participants? Someone was trying to say something. Okay. What were the results? So the first plot that Dr. Omar shown, there had the results, had the answers that sacubitril-valsartan definitely has a mortality benefit and decreases the risk of hospitalization in heart failure with reduced ejection fraction, and just reduces the rate of hospitalization in those with preserved ejection fraction. So, and they were so, are there any questions or any comments from any other participants?
all right.
So I would.
So either I explained it well enough or I confused everyone enough that they don't have any questions.
Then we conclude this session. Thank you, everyone.